Hey there, I'm Meg Bowman. I am a licensed dietitian nutritionist who specializes in mental health nutrition through the functional lens. And today I'm going to walk you through some of the things that I do with my clients to make sure that they feel safe in session and that they can actually do the things that we're talking about. So this is our agenda for today. We're going to talk about trauma and how that impacts health. We're going to look at how specifically you might know whether trauma or chronic stress are impacting your client's health, maybe your health. And then we're going to finally look at how do we actually go about personalizing a nutrition approach, whether that be medical nutrition therapy or coaching or some other way to really speak to those people who have experienced trauma or who are under so much stress right now. So let's dive in. All right. So this is the first section. We want to talk about how does trauma impact health? This is a huge, huge, huge thing. You know, when I was trained in school, I was a career changer. So I've been at this job for about 10 years now. When I was trained in school, I was trained in the functional medicine model of nutrition, which always looks at what is the root cause of any given condition or symptom. And I got to tell you, I think I found the root cause for just about everything, and that is stress and trauma. Sincerely, depending on the study, anywhere between 60 and 90% of primary care physician visits are due to stress and trauma. If you're curious about reading a little bit more about that, that 2013 study is from JAMA, and it's a very good one. But this is bonkers, you know, and it's not that people are going to their physician and saying, oh, I'm so stressed, doctor. What do you want me to do? That's not what's happening. What's happening is their bodies undergo stress, the HPA axis, the microbiome in the gut gets wonky. And when that happens, it causes symptoms and it can potentially cause disease. So one of the things that I'm always curious about is when a condition or symptom or something is happening where the client isn't feeling optimal, what's underneath it? And an awful lot of the time, it is stress or trauma, right? And it really doesn't matter how big the stress or trauma. This is a quote from one of my favorite therapists who I was given permission to use. But this idea that, you know what, you don't have to get a gold medal in trauma for it to impact you. I think often as people, we do this weird thing where we say something like, oh my gosh, I'm so stressed, but I'm not as stressed as that person, or what I experienced wasn't as bad as that person. Therefore, I don't get to have my feelings. No, 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 no. Body keeps the score. Your body is aware of it. So really, it is more about the perception of stress, the perception of trauma, than trying to make sure that you deserve to talk about this, you know, and to have it impact your life. So what is trauma exactly? I'm going to define it just like the Substance Abuse and Mental Health Services Administration defines it, which is, it is actually the thing that happens. It's also you experiencing that thing. And then it's also what happens to you after that happens. You know, I don't know if you've ever, this is a little T trauma kind of example, but if you've ever had a near miss on a highway, right? And in the moment, your adrenaline shoots up and you might be shaking afterwards. And days after, you might have nightmares about it. Guess what? That's trauma. Whether or not big T trauma, little T trauma, it's traumatic. And at least 90% of the population has been exposed to some sort of traumatic event. And so when people ask me, you know, how do I know who to screen for? My answer is like 9 out of 10, you got to screen everybody, literally everybody. And what's most important is whether they define it as being stressful themselves, right? So don't take your opinions, take theirs. So then once we've assessed that, like literally everybody, we need to be aware of this for literally everybody. How do I know whether that experience is affecting their health? Because of those 90% of people who have experienced a traumatic event, only 20% get PTSD. So how do we know within that group who needs additional help? Okay. So some of the things I look for are social determinants of health. Social determinants of health are factors, generally speaking, outside your control that greatly greatly impact your health. And you don't think about it. Here I am sitting in the Chicago suburbs. Um, I am in a safe neighborhood right now. I feel very fine getting out, walking my dog. I don't even lock my door. I feel very comfortable doing that. There are people who aren't in that situation, or there's people who, when they go outside, there is nowhere to walk, there is nowhere to be, they can't be outside, right? That's going to be detrimental to their health, or it can be. We definitely know there's links with education. The more education somebody has, the better their mortality. I kid you not. It also gives you better access to healthcare. If you don't have access to healthcare, that is a big problem. And then finally, the discrimination and marginalization. I will tell you, everything on this list, everything we talk about today, trauma is inflammation. I just want you to put that in your brain. Trauma is inflammation. But the amount of inflammation that comes from discrimination or marginalization, racism, these little quips that you just constantly get that just like eat at you. This stuff isn't great for our health. And a lot of times people come in and they think, oh my gosh, I'm doing everything I should be. Why am I not feeling better? Good too. There it is, right? So let's look at a couple of different ways that social determinants of health play out. So here's one. In this study, they looked at what % of adults that were 25 or up have an activity limiting chronic disease, meaning they have some sort of disease that they find it really hard to live life the way that they want to. So I want you to take a look at this. So what we're seeing here is the family income at the % of poverty level. So are you less than 100% of poverty level, meaning are you below the poverty line? Are you slightly above the poverty line, or are you way above the poverty line? So those below the poverty line have a roughly 30% chance of having some activity limiting chronic disease, versus those who make significantly more than poverty line. They only have less than a 10% chance of having an activity limiting chronic disease. Here's another way to look at social determinants of health. So this is life expectancy at age 25. You'll see it does differ versus men versus women. This population did not look at people that might identify differently than men or women, which I think would probably give us different data. But as you can see, the more education that people have, the longer they live, the longer their average lifespan. So these ideas, social determinants of health, are very, very, very good for you as a provider to try and understand what's happening in your client at home, what's happening in their environment. Do they have access to healthcare? I'm going to tell you my very favorite handout that I've ever found on this is at this website, determinantsofhealth.org. I have no relationship with this organization, but they have this amazing handout that you can actually download and show your clients that really brings into immediate focus, like how much of my health is due to me and my activities, how much of my health is really due to the things that are happening around me or being done to me. So it's really a very helpful thing to take a look at. ACEs is another thing that I try and screen for in my clients. So ACEs is adverse childhood experiences. We've known for years and years and years that having any number of adverse childhood experiences, your parents divorce while you're in childhood, there is abuse in the home, somebody goes to prison, any of those things can increase your risk as an adult of having both chronic mental health and physical health issues later on. So trying to understand what your client's ACE score is, an ACE score of 1, they've had one of those things, their parents divorced, versus an ACE score of 4, that's somebody that you definitely want to do some more careful thought around how could we increase anti-inflammatory support for that person. Because ACEs fuel disease. No kidding. Look at this. So the chance that you get type 2 diabetes is 1.4 times somebody that doesn't have adverse childhood experience. Chronic pain, you got twice the chance of getting it. Stroke, cancer, or heart disease, 2.3 times. Let's keep moving on. Major depression, that is 5 times the chance of somebody without adverse childhood experiences. Drug use, 10 times. Suicide attempt, 37.5. So this is something, if you're working in the world of mental health nutrition, that you're going to want to screen for either formally. There are definitely ACE screeners out there you can find, or I honestly kind of prefer an informal, just asking the question, hey, did anything happen in childhood that was really challenging for you? Just to see, because it really does change as providers how we help that client focus on what to do. So here's some correlative data. These are all based on studies. When our bodies experience trauma, our bodies, well, let me give you a different way. There's this phrase that I stole from another therapist. I steal all my best work from therapists, let's be honest. And her phrase was, if we don't feel our feelings, we get issues in our tissues, which I think you can see here. There are some things that we can't control. Sexual harassment at work does have a correlation to hypertension, right? Racism has a correlation to diabetes because of all those microaggressions. Literally, our body interprets those as stress. Of course it does, right? And even something like shift work, which maybe isn't cognitively traumatic, although I'm not gonna say that. You folks that do shift work, you tell me whether it's cognitively traumatic. I'm not sure about that. But we wouldn't necessarily say, oh my gosh, shift work is trauma. And yet our body interprets it to be traumatic. There's a lot of different data on shift work. So then the question becomes, all right, if we know what trauma is, if we know it kind of doesn't matter whether or not it's big T trauma, little t trauma, if you're experiencing it, it's probably affecting you. We roughly know what we're looking for. Then comes the question, like, how do we actually figure out what to do in this instance? And so one of the things that I like to walk people through is just this division, right? This is a lovely Venn diagram that shows you trauma-informed approaches is very different than trauma nutrition, okay? Trauma-informed approaches mean you're doing things very intentionally to help people feel safe in their bodies. That's what we're going for. Trauma nutrition or mental health nutrition are the foods that we eat to feel safe and feel regulated. Now, there is a way that, if you have a provider who is not trauma informed and they are trying to help you with your mental health nutrition, and they say, hey, I want you to eat and give you this diet that you're supposed to follow, but you as a child were restricted from foods because your parent was trying to get you to lose weight. They might have just traumatized you because they did not do it in a trauma-informed way. So what we're trying to do in mental health nutrition, medical nutrition therapy, and in coaching is try very hard to hit that Venn diagram where we're helping people access the foods that are going to help their mental health, but we're also doing it in a way that's not going to re-trigger or re-traumatize them. Okay, so I got to tell you, I have been through nutrition school myself. I am a mentor for early nutrition career professionals that want to get their CNS, which is a functional nutrition cert. I'm faculty at Nested Health Coaching. And I got to tell you, every single thing, every place that I've ever been to go to school to learn about how to do nutrition focuses on how do you assess for what's wrong, right? That's not a very trauma-informed approach. How do I assess for what's wrong, right? Some of the things that I didn't learn in school, I don't know about you, I didn't learn to include any screening on my intake forms or verbally during sessions. Sure didn't learn that. I definitely immediately, when I was first out of school, sent a 3-day client diet diary with the intake forms before I'd ever talked to them. Like, fill this out. That's a little problematic. At a certain point, I was sending clients updates. I would send them a protocol in Practice Better, and I would have my nutrition diagnosis immediately visible, which is not always helpful, that kind of information. And then we are trained to give people information about limit your fat intake, limit your carbohydrate intake, no more than 2 sodas per week. It's all about these rigid boundaries. That's how we're taught in school. And one of the things that you need to learn when you're working with a population that is, really sometimes has experiencing tremendously difficult things is this doesn't work. This doesn't work. So let's talk about what actually does work. So there's some things that I think you can do actually just within tech, within the software that you're using, that are going to make it much better, both for you and the client. The first thing, we're going to go over each of these things individually, so don't feel like you have to, frantically get these down. The first thing that I would recommend, you gotta include some screening questions on your intake form, because as you saw, 90%, that's 9 out of 10 people have experienced some sort of traumatic incidents in their lives, and you're trying to figure out who those people are and then what to do. The second thing that I would recommend, I know you probably have this automation set up in Practice Better, where the second that a client books, you have the automation set and they will get all the forms and they'll get the 3-day diet diary. I would not do that. The reason that I would not do that is because there are actually a number of steps that I feel it's really important to take before we send that. And there's a way to use it that's going to be helpful, rather than, there's a percentage of clients that it's going to be harmful. So we're going to send the food journal only after we screen people and we make sure that we know who it's safe for and who it's not. We're definitely, when we use the nutrition journal, hey, how about you hide the data? You can do this. You'll still see it. Just the client won't see it, at least at first, as you're watching for patterns of disordered eating or trauma. And then the other thing that we're going to try and do is use experiments. So I'm going to give you a personal example. I hope you don't mind. I have ADHD. I wasn't diagnosed until my 40s. I was totally the kid in middle school who had papers scrunched in the bottom of her backpack, desk always messy, locker always messy. A teacher would give me a document that I had to sign for a field trip, and I swear that thing disappeared instantly. Like, it hit my hand and it was just gone. Who knows where it is? That was me. And so throughout my life until my diagnosis, I always had this feeling like, why exactly am I not able to do things, right? And it really wears on you. So because of that, I like to use the phrase experiment rather than homework, because a lot of people have kind of a bad association with homework, like me. I don't use words like accountability. Now, some people might see that very helpfully, but I don't use that because it always feels very pedantic to me. And it feels like, oh, you got to be accountable, because that was my personal experience. I don't use words like compliance. I hate that word, even though I know that some of us were taught to use that word in our documentation. I, as an individual, hate that word, because it just feels like all those times when I got home and I was supposed to have my parents sign a form for my teachers and I couldn't find that form, non-compliant, right? Now, these things are just me things. They may not be your client things. So one of the things that I would ask you to do or think about doing is really use experiments and ask a lot of questions around what language does feel good to you. That way we can be more inclusive with our client care. And then finally, although frankly, this probably comes first, we're going to try and assess for nutritional sufficiency specific for mental health. So let's look at these one by one and talk about them in just a little bit more detail. So the first thing, here's 4 questions that I would include on your Practice Better intake form. You're going to ask, do you have a history of generational trauma? Maybe their family lived through Hurricane Katrina. That's important to know. Maybe their family lived through the potato famine in Ireland. That's important to know. Whatever the experience is, we know that can kind of go from that trauma can go from generation to generation. So it's just important to know. You don't need to know a ton about it. Just yes, no, do you? That's great. I love to ask on a scale of 1 to 10, what is your stress level most days? And even though the client is going to give me a number here, I don't necessarily trust it. Because sometimes we do that thing where in our head we go, oh, okay, On a scale of 1 to 10, man, I really want to put an 8. I really, really, really want to put an 8, but my neighbor was just diagnosed with cancer, so I don't think I can put an 8. We do this weird thing in our head, right? So take it as a data point, not as an end to the conversation. I always ask a couple questions, even if I'm not dealing with somebody that I think has an eating disorder or disordered eating. I always still ask, has anyone been diagnosed with an eating disorder? Has anyone in your family participated in chronic dieting? Because we know there is a huge genetic link, especially for eating disorders. So if somebody in their immediate family has been diagnosed with an eating disorder, you are going to tread much, much, much more carefully when it comes to any restrictive type of food activities that you might do. That's a great example of why, like in mental health nutrition, I am all about adding things versus taking things away. Actually, when you meet the client, this is a great opportunity to ask some of these questions. You'll notice on the intake form, I didn't say, have you experienced personal trauma yourself? I don't ask that on the intake form because I want to ask it in person. I want to see what that client responds, and I want to be able to change my response and help them through it if they have a moment of fight or flight. So I always ask, you don't have to give me details. That doesn't matter. You don't have to, you can if you want to, but you don't need to. Have you experienced any periods of personal trauma, high stress periods in your life? And then the next question you got to ask is, when did your symptoms start in relation to that time? And boy, 9 times out of 10, something happened and then they get sick. If you want to dig into it, there is a really kind of interesting study called Holmes and Rahe, R-A-H-E. I don't know how to pronounce that guy's name, but if you look up the Holmes and Rahe, R-A-H-E, you can see there's actually a metric that helps you walk through your risk of getting sick in the next number of years based on what's happened to you. It's quite interesting. So we're going to screen in session about personal trauma. We're also going to screen prior to giving any food journal in Practice Better. And some of the questions I ask, what's your relationship to food like? I asked people, have you ever felt hypervigilant? Like, did you ever read a study and they said that we shouldn't be eating XYZ? And so you got very anxious about eating whatever that food was. Or have you ever used a food journal? What happened? You know, sometimes people feel they want to go, okay, I don't know who I should use a food journal with and who I shouldn't. Yeah, I don't know that either. I have no clue, but I'm going to ask. So feel free to ask. If we were to do this, do you think it would change your eating habits? If we were to do this, what feelings do you think came up for you? One of my absolute favorite things to ask in relation to this is, have you ever done a New Year's resolution that involved food? How did that go? That's going to tell you so much, so much. You know, I did this New Year's resolution where I said that I was going to be free of sugar, and all I thought about for the next 6 months, anytime I'd eat anything, even fruit that had a modicum of sugar in, was how bad of a person I was. That's important data to get before you give somebody a food journal, right? Where you're really shining the attention on their food intake. Okay. When you do give the food journal, I'm going to tell you, my preference is to, for everybody, turn off the nutrition data for the client for a while. You don't have to do this for forever, but at least for the first couple weeks that you're using it, turning off the nutrition data so that you as a provider can, you know, not only verbally ask about the disordered eating trauma patterns, but also literally watch for them and see if they pop up is really, really important. So what are we going to watch for? We're going to watch for very limited diet diversity. If somebody eats the same exact things for breakfast, lunch, and dinner, does that mean that they have eating weirdness? No. I will tell you, my ADHD, I am really on this really weird hard-boiled egg kick for breakfast. I don't know. I don't know why. But hard-boiled eggs with just like a little bit of Mike's Hot Honey is just bonkers delicious. And so that's what I've been eating. And so if somebody that didn't know me would go in and look at my diet diary, they'd go, what the heck is this? And it isn't a disordered eating thing. It's an ADHD hyperfocus. No big deal, right? In 2 months, I will never eat that thing again in my entire life. But there are some clients for which that is a trigger. And so you're going to ask more questions. Definitely people coming in for mental health, if they're eating low calories, you're going to want to figure out why. If most of the food is eaten at the end of the day, that is something to also investigate if there isn't a reason for it. Maybe they work all day. I had a client who was an anesthesiologist and literally couldn't drink or eat when he was at work because he might be called into surgery at any given time. So he ate most of his food at the end of the day. That's normal. Well, it's not normal. I felt bad for him, but it's not disordered, right? We're looking for instances where trauma or disordered eating are impacting people. People that have cheat days, that's always interesting. That's an interesting pattern. And I do recognize that a lot of people use it and use it no problem, but there are people who use it pathologically. There are people who use it problematically. And you're going to try and search for those people that feel horrible on them about themselves on those days, right? You're looking for that. You're also using some of the other tools that they give in the food journal, like where are you eating? How do you feel when you eat? Just understanding whether that client is eating always alone, always with others, like that can be a place that food weirdness or trauma can sneak in. If you have a client that has a long cultural history of eating a certain way and they're eating totally different, wow, that's something to investigate. Because a lot of the time people feel a lot, you have second generation immigrants to the US and they feel like they have to eat in the way that we eat here in the US. I don't know what that is. I don't know what normal is, but they feel like there is a way. And all of a sudden they change their eating patterns, potentially to their detriment. So being aware of that certainly is something that happens with trauma. And then being aware of shame or good or bad language. Hey, I was so bad today, typey, typey, typey. I ate blah, 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 blah. Like that's interesting language to maybe indicate that there's a little bit going on with some trauma around food in the past. At least get curious. Okay. So the next thing that I'm going to recommend is that we are going to create some experiments, not homework. Again, if the client is fine with using homework, you do you. But I don't like to use homework. I use experiments because if a client chooses an experiment and isn't able to do it or it doesn't go well, that's just data. There's no shame in that. There's no blame in that. It's just data, right? We know if we talk in session that I want to add another vegetable every day to my diet, and I come back the next week and I haven't done it. Our inclination as humans is to frankly cancel the appointment. So we don't want that, right? So if you go in with this narrative of we're going to do an experiment, and if it doesn't go well or you can't do it, it's data. And that data is going to tell us whether it wasn't the right intervention in the first place or whether it wasn't the right time to do that intervention. It's going to take all of that shame away. And then you are going to increase your client retention because they are going to come back. You and I both know, oh my gosh, I might be this person right now. I'm not going to lie. I'm seeing another provider for some help with some herbal stuff. And, I would avoid that session if I hadn't done the things that we had talked about, if I didn't know that he was interpreting it as an experiment and that maybe it wasn't the right thing. So use that experiment model. Find an experiment that's small. Can't tell you how many times in my career, I'm in my home office right now, but back in the day when I actually had an office outside my house, before COVID, I would have people that would come in and sincerely, they would bring like this massive binder and they would plunk it down on my coffee table and they would say, I went to this other provider. They gave me this binder. In this binder are all of my labs, all of my supplement recommendations, my entire meal plan, and I don't want to see them anymore because I don't know what to do. Plunk. So find something really small to start with. And if you can have the client identify it, do that. We're going to prioritize the ability to eat over eating the right foods. In trauma nutrition, trauma-informed nutrition, we prioritize the ability to eat over eating the right foods. I will give you an example of this. I was talking the other day to a dietitian, not my client, just somebody that I'm acquainted with. and they had recently had a loss in the family. And she told me that she just couldn't eat. She absolutely couldn't eat. And over the next 2 months, she lost about 15 pounds because she sincerely could not eat. And all these well-wishers around her were saying things like, oh my gosh, you look amazing. Oh my gosh, you lost weight. This is amazing. And she's sitting there going, I just lost a relative, So definitely we need, when we're working in mental health nutrition, to prioritize the ability to eat, period, over eating the right foods. I'll give you another example. I had a client that I saw them for almost a year before we could focus on vegetables. And the reason for that is, as a kiddo, they were put in on so many diets as a kid. And they were only allowed to eat vegetables for snacks at home, and meals were entirely vegetables. And so as an adult, eating a vegetable was frankly this really traumatic thing for them. And it took a year, just about a year, of just saying, eat what I just need you to eat, period. I just need you to eat, to get to the point that they were able to eat vegetables. And when that regulation happened, when they were just like, okay, food is good, any food is good, it is okay for me to eat, is it okay for me to eat? Eventually they came to session and they said, I kid you not, I went to a restaurant this week and I ate an arugula salad. And as both you and I know, arugula is a really aggressive lettuce. So that was really impressive that they were able to do that. So prioritize the ability to eat over eating the right foods when you're in the mental health field. And then also focus more on the holistic well-being than the labs. If we're so focused on, oh my gosh, we got to get this cholesterol down, or oh my gosh, we got to get the blood sugar down, or whatever, the labs will follow if you focus on the holistic well-being, if you get that client feeling better. Okay. So then finally, the last thing that I'm going to say is create ways to assess for nutritional sufficiency. So there's many, many, many ways to do this in Practice Better. I personally would have a section in my chart note that would include prompts, because again, I got ADHD, I can't remember stuff. I would include prompts, to assess for these things. You could also create snippets, those little chart notes parts where you're in a client note and you're like, oh my gosh, I can't remember how to assess for blah, 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 blah. And you bring up a snippet and that information is right there. So these are the things that we're looking at. You certainly want to know that they're eating enough. You want to look at their macros and micros. You want to look at how much color they're eating. Let me tell you, you really do want to look at how much color they're eating. There's a lot of data on polyphenols and mental health, so that's really important. If we start getting into some of the funky, sexy functional med stuff that we don't have time for today, when I'm with clients, I'm definitely looking at the nutritional cofactors for neurotransmitter production. I'm looking at what's happening in the microbiome. Do they have enough BDNF to literally change their mind about how to be with things? Are they eating the anti-inflammatories? Are they eating all of these things that are going to help them feel better and feel safer in their bodies? So I would encourage you, if you're interested in this, in looking at some of the studies on mental health. We're going to look at one, which is the Mind Diet, but there are others. There's the SMILES trial, there's PrediMed, there's a number of more large-scale studies that look at this. And, some of the things that we find is that it's really important to consider diversity. Lower diversity has been shown to be correlated with anxiety and depression. Always higher intakes of fruit and vegetables and color is helpful in the literature. That's pretty clear. It's pretty clear that we do need to have enough fiber to really influence the microbiome and the way that it works and the inflammation that might be coming from the biome itself. So trying to provide foods for that. But this would be my first list. Like if we look at the Mind Diet, which is what this is, I, as an individual, feel overwhelmed when I look at this, completely overwhelmed. You give this to somebody with treatment-resistant depression, they're never going to see you again. Never, never. They are running out that door because this is impossible to implement. So I'm going to go back to these things are my favorites to start with, because generally speaking, they are reflected among multiple studies. Absolutely have that client increase color. If you get regular carrots and it doesn't cost you more to get the colored carrots, maybe get the colored carrots. If you get the regular cabbage, get the red cabbage. If you get sweet potatoes, orange sweet potatoes, maybe try the purple ones. Anything that you can do to increase color in food is going to be helpful. Almost anything you can do to increase fiber is also going to be helpful. And then olive oil, man, every single study that is Mediterranean based on mental health includes intentional use of olive oil. So do that. And then finally, possibly the most divisive, asking a client to increase vegetables is not always the easiest thing to do, but that is something else that's really important to consider. So when we look at this, this is the MIND diet. The reason that I picked this one versus all the others that I could have picked is because it's generally a little bit less aggressive on the vegetables. So 1 serving a day, and then roughly 1 serving a day of green leafies. Some of the other studies out there have, 5 to 8 vegetables per day, and it's just a lot. So with a lot of clients, I like to start with literally small things. Like, let's just look at one thing. Okay. So of course the MIND diet also does have a little bit of restriction, but again, that's not what I'm focusing on. I'm focusing on adding things in. So I had one of our team members make this for me. This is an actual diet for a week. I personally wouldn't give somebody a meal plan like this. You give somebody with treatment-resistant depression this, and they go, I don't think so. We're not going to manage this. But you can certainly look at it as a recipe packet. And the reason that I gave it to you in this format, I was very intentional of showing you this, is literally it is possible. We use that Clean Life integration that comes with Practice Better, that you can get with Practice Better. And we literally hit every single target on the MIND diet. It is on this page. So it is actually possible to do this. And again, you're going to start with one thing. You're going to start with a single thing. One of my favorite things to start with a client who doesn't know where to start is something my mom taught me. She taught me years and years and years ago, if a recipe calls for 1 tablespoon of an herb or a spice, just double it. Just double it. Whatever the recipe calls for. If it's an herb or a spice, like a dried herb or a spice, just double it. And I have done that for years, and it really does make an impact. So you're going to pick something very, very, very small for the client to do. Okay. So if you make these changes, if you make the edits in Practice Better to your intake forms, to your notes, to how you're handling the food diary, and then you look at the studies based on what are we going to do to improve mental health with nutrition. And then you pick one single thing. Frankly, how about the client pick the one thing? That would be great. You are definitely going to be miles ahead of your peers about using a trauma-informed nutrition approach or coaching approach. So thank you so much. Greatly appreciate that you were willing to listen to this and engage. The references for those of you that are interested are here on the slides, so you can learn more about the studies that I talked about.